Joining us tonight to talk about your health is Dr. Sumon Nandi, orthopedic surgeon at the University of Maryland Medical Center and associate professor of orthopedics at the University of Maryland School of Medicine. Doctor, thank you so much for joining us.
Thank you so much for the opportunity to speak to you and your distinguished audience.
Tell us, what are the top procedures that you do?
So my practice is exclusively focused on hip and knee replacements. So those are the surgeries that I do and I enjoy doing.
Is it more of one than the other?
So knee replacements are just more common because knee arthritis is just more common. So as you said, over 1 million people a year get joint replacements in the U.S. alone, which is really amazing. A little over 500,000 patients a year get hip replacements, and 700,000 some patients get knee replacements a year.
Is it mostly driven by arthritis? What are some other conditions? Basic wear and tear, can that lead to the need for surgery?
Yeah, absolutely. So that's exactly correct. So arthritis is a process. It's not a thing. It's a process by which the cushion in the joint wears away, and then the bones grind against one another, causing pain. And that can affect any of our joints, but it very commonly affects our hips and our knees. And when patients develop arthritis to the point where all the cushion is gone in their hip or their knee, and they've tried everything short of surgery, like anti-inflammatory medications, physical therapy, a cane or a brace or various types of injections, and they still can't live the way they want to live, then they're a candidate for either a hip or a knee replacement.
Is it one of the things where, like, a year after you operate on somebody, if you see them for a follow-up or something, they say, I can't believe I waited that long. I should have done it sooner.
Yeah, absolutely. That's something that we hear commonly, you know, but it's a balance, you know. You certainly don't want to do a hip or a knee replacement as a preventative measure, right? Not at the first signs of arthritis do you want to get surgery. You want to try everything short of surgery first, and that's certainly my approach. So we try everything short of surgery. We make sure that you've got end-stage arthritis where all the cushion is gone, and you're to the point where you say, you know, I just can't live like this anymore, or I can't do the things that are really important to me, and that's when we pursue surgery. But oftentimes, you're absolutely right. Patients say, you know, this is just fabulous. I'm able to do the things I want to do, and that's what makes my job so wonderful and one that I really love doing.
What's the age range of your patients commonly for a replacement procedure?
Yeah, so it differs for hip and knee replacements. You know, the majority are 50 to 70, around that range. But for knee replacements, the studies have shown that if you do a knee replacement in patients younger than 50, the results aren't as favorable. So
why would that be?
Yeah, so we rely on the data from those 1 million plus patients a year who have hip or knee replacements. And so we have a lot of data on how to get patients to do well. So we rely on that to really inform our practice. So that data shows us that if you do a knee replacement in someone younger than 50, there's an increased risk of infection, and there's an increased risk of the pieces and parts getting loose sooner than they otherwise would. So we don't want that. We want to do the surgery and have that patient be good for the rest of their lives. So that's why we really try to do knee replacements in folks who are 50 years of age or older. Now, there's no such data in patients who have hip arthritis and need hip replacements. So I've done hip replacements in patients in their 20s who have certain conditions, not necessarily arthritis, but other conditions that can affect the hip joint and damage the hip joint to the point where they need a joint replacement.
Let me remind our viewers, if you have a question about knee and hip replacement surgery, give us a call at the number on the screen, or you can send an email to livequestions@mpt.org. What advances in the time you've been practicing? Have surgical techniques changed? Is there a role for robots here? And how about the hardware itself? Is it better in some way than it used to be?
Yeah, sure. So fabulous question, and I think one that's on the minds of the audience. So I would say the most impactful advance in the field of joint replacements is rapid recovery joint replacement. So in the late 60s and early 70s, when hip and knee replacements first came out, patients would come to the hospital a few days prior to the surgery and stay for weeks afterwards. And now patients come in the morning of surgery, they walk the same day, and they go home the same day. So that's been the most impactful advance. And you know, it's not just a novelty that we're able to send patients home the same day. It really has been shown to improve the outcomes of the surgery and decrease the risks. So rapid recovery joint replacements have really been a wonderful boon for hip and knee replacement surgery.
And on the robot thing, there's some
Yeah.
procedures where it just changes the world, but this one, you
Yeah.
wouldn't figure that.
Yeah, so again, when I make my decisions about how to treat patients, I hang my hat on the data, right? We can't do things just based on opinion or conjecture or just because I like to do things a certain way. There has to be more sure footing when it's an issue of someone's life or limb. So if we look at that data shows us that if you do a joint replacement using robotics, there's really no significant advantage. In fact, there was a really elegant study that was done in patients who had arthritis in both of their knees. All right, so the same patient, both knees are arthritic, both need knee replacements. One was done using manual instrumentation, and the other one was done using a robot. And the researchers followed these patients for 10 years. So it was a really wonderful study that found that there was no difference in pain, function, range of motion. The patients didn't like one knee better than the other. There was only one difference, and the difference was the knee done using robotics took longer. So, you really don't want to spend any more time under anesthesia than you'd like.
Yeah, I want to get to the phones, but if somebody needs two knees done, do you do one, wait 6 months and do the other, or is it possible to do them both at the same time?
Yeah, so the first option is more favorable because there's actually some recent evidence that shows that even in someone who's perfectly healthy, if you do both at the same time, the risks are higher. So, you got to look at what you're starting out with. Now, of course, knee pain can be debilitating, but at the end of the day, it's just knee pain. So you don't want to put someone at any increased risk when you can certainly do one, and then 6 weeks to 3 months later, you can do the other side. And what's interesting is if you do one knee, sometimes the other knee stops hurting because the one you did does its fair share of the work. So you can get away sometimes with just doing one surgery.
Interesting. Let's go to the phones. Lisa in Allegheny County. Thank you for calling. What's your question?
Thank you for taking my call. 10, 20, 30 years ago, there was a big push on exercise, running, walking, biking, etc. Did we kind of shoot ourselves in the foot by ruining our hips and our knees?
We all should have just sat around in rocking chairs, right?
Well, some of us did.
Great question. Thank you very much.
Yes.
Do you see the weekend warriors, the people out there cycling or running, do they need your services more often?
Yeah, so I would say that exercise is a great thing. So if you really, took that advice to heart and started exercising, you did what was right for your overall health, okay? Exercise has been shown to be beneficial in so many regards, all right? And the other thing it does is it keeps your weight at a favorable level, all right? As a result, the load going through your joints is less. So what's amazing is 4 times your body weight goes through your knees when you're doing stairs. So if you weigh 100 pounds, I certainly don't, but if you weigh 100 pounds, 400 pounds of force goes through your knees when you're doing stairs. Imagine that. So by keeping your weight at a good level, there's less load going through your joints, and as a result, the likelihood that your joints will remain healthy is increased. Now, if you can avoid repetitive high-impact activities and still stay in shape, by doing things like the elliptical, which is a low-impact exercise, right, but still load-bearing, you're putting load through your joints, that's good for your bone health and bone density, then that's really the ideal.
Back to the phones, Montgomery County. This is Charlotte. Thank you for calling. Go ahead.
Yes, hi. Thank you for taking my call. I have a question. After an X-ray, should you get an arthroscope to see the internal mechanisms of the knee to
Great.
see if you ripped a meniscus or something?
Great question. Thank you.
Sure. I can understand, the sentiment behind the question, which is, boy, we'd better be sure about what's going on there before we choose a treatment plan. But the X-rays, even though they're not fancy, right? They're not as fancy as the MRI, but they're really, really informative. In some regards, they're more informative than some of the fancy tests like MRIs because you're putting weight on your legs when you get an X-ray. And so when it comes to joint replacements and arthritis, the X-ray is sufficient. If you see that there's no cushion left on the X-ray, right, and the patient has tried everything short of surgery and you can't live the way you want to live, then that is enough information to proceed with a joint replacement, and you avoid all the risks of an additional surgery like arthroscopy. It has been shown that arthroscopy is not beneficial for arthritis.
Email question. Viewer wants to know, what does the doctor think of hip resurfacing instead of full-on replacement?
Yeah, so let's draw a distinction. It's a very sophisticated question, which we love. So let's draw a distinction between resurfacing and replacement. So the hip is a ball and socket joint, all right? So the top of the thigh bone is the ball. The socket is on the pelvis side. So when you get arthritis, the cushion in the joint wears away. The bones grind against one another, causing pain. In a hip replacement, we take the arthritic ball, we remove the arthritic ball, resurface the socket with a metal socket and a plastic liner, put a stem down the thigh bone, ball on top. That gives you nice smooth surfaces that glide against one another, as opposed to your bones grinding against one another. That takes away your pain. Let's contrast that with resurfacing, which was the caller's question. So in a resurfacing, you cap the end of the thigh bone or the ball with metal, and then you put a metal socket in. So resurfacings were really popular about 10 to 15 years ago. And they were put in with the best of intentions. But when we followed these patients out, right, and we looked at the data, what did the data show? The data showed that in a resurfacing where metal is grinding against metal, metal ions would be released into the hip and into the bloodstream and would cause various problems. And there was
we got to leave it right there. That's a good point to leave it. Dr. Sumon Nandi of the University of Maryland Medical Center. Sir, thank you very much.
Thank you.